Welcome, everybody. This is Robin Young for our second Ask Lisa Masterclass, and we have with us the one and only Lisa Ferrara, PhD. And our topic for this masterclass is a really interesting one. We're going to explore every facet of the facet joint. And to kick us off, and we did get, and thank you, by the way, to our audience for giving us so many questions and so many really good, tough questions. We'll see how well Lisa navigates all of those questions. So without further ado, let me introduce my dear friend, Dr. Lisa Ferrara. Lisa, how are you doing today?
Good, Robin. Thank you so much for inviting me again, and thank everybody for your insightful questions. I'm doing okay. I'm ready. I'm excited.
Right. Well, I've always been fascinated, frankly, with the facet joint. I think it's underappreciated, understudied, and I'm hoping today we can shed a lot of interesting light on it and where we go with treating the facet joint. So first, just to begin, why don't we start with an overview of the form and function of the facet?
I think that's a great idea. I am a major fan of the facet joint and facet fixation. Let's start with just the basic function of the facet joint. We know that it transmits the compressive loads along the spine. It does provide torsional stiffness. It provides resistance to axial rotation, torsion, to shear, to translation. And the joint capsule actually resists the distraction of the joint as you go into flexion. What I want you to keep in mind when we think about the biomechanics of the facet joint is its form and its function. We always talk about form follows function. And the facet joint's a perfect example of form and function. The normal facet joint is a complex synovial joint. It's cup-shaped under compression, but it's cup-shaped from the anatomical form. And that's important to understand because that shape dictates its function in resisting shear, rotation, and translation. It produces a fluid to nourish and lubricate the joint along the cartilage surfaces so that the facet joint slides, the superior to the inferior slides along each other. And of course, it assists in the disc in load sharing, but its main function is a mechanical stop in the rotation and also in extension and in shear.
And translation too, right? It
And
does
translation,
translation.
yes.
Yeah. Okay, great. Thank you. This is
So
yeah.
let's talk about the biomechanics of it from a load transfer, or what I call load balance perspective. We'll start with the degenerative process. So when you look at that load balance in the normal spine, the vertebra and disc take up about 55 to 60% of the 80-20 rule. Punjabi came out with 80% of the axial loads go along the anterior column of the spine, and 20% approximately are transferred to the posterior column of the spine. With that, the vertebra and disc obviously take up the most of that anterior column load, and the cortical shell is about 10%. The ligaments are 10 to 15%, where they pull the stresses and forces away from the disc and the vertebral bodies. And the facets actually see about 20 to 25% of that posterior load. In the degenerative spine, this profile changes significantly. The vertebra and the disc really are inefficient now and can only absorb about 40% of that anterior column axial loading. The cortical shell, it may actually increase in what it has to see and absorb because now you've got a degenerative disc, but it stays about 10%. It might increase a little bit from there. The ligaments will become less efficient at transferring that load and those stresses. So it may be 10%, maybe slightly less. And now the facet joints are really taking the brunt of this change in load distribution. And they're seeing about 40% of that load going posteriorly. So it all starts in the disc. The disc is the first to start that degenerative process. In the normal healthy disc, the hydrostatic pressure has good integrity, obviously. The lamellar fibers are oriented in their 60-30 degrees, and they're layered in this manner. And that structure, form, and function actually helps resist tension, torsion, shear, translation, along with the facet joint, obviously. But it's really at that state of equilibrium. that we're seeing in the healthy disc. But when it starts to degenerate, that's when everything goes awry. You get a loss of integrity of that hydrostatic pressure. When you load the disc, now that you've got a loss of fluid as well, you actually get an eccentric buckling of the fibers. They're not uniformly, they don't bulge uniformly under compression, for example. It becomes very eccentric as shown in the lower figure. And it's not capable of adequately bearing those axial loads, taking up that 55 to 60% of loading. So what happens is, okay, I can only take up maybe 40%, that load is transferred posteriorly. Keep in mind, as the disc degenerates and it loses fluid, it also may lose height. And at that point, you start to have changes in the ligamentous complex. The ligaments are there, they remain in taut in tension, but with degeneration and with a loss in height and with a loss in fluid, they might become lax, they become weak in their stability with respect to transferring the stress away from the spine. And they may become thickened and stiffer and develop traction spurs and spondylitic spurs. And finally, when all the soft tissue becomes a degenerative complex, it's now where you start to see changes in the facet joint. So the facet degeneration often is secondary to disc and soft tissue degeneration for obvious reasons, but that transfer of load to the posterior column can result in cartilage degradation and focal diffuse erosions, and the repeated increased pressure, increased forces can result in erosion and thinning and sclerosis of subchondral bone. But mainly you'll see things like hypertrophy of the facets and angulation, and not uniform angulation. You'll have asymmetric angulation of the facets, even within the same vertebral segment. And of course, osteophyte formations, which is what we see when, because of Wolff's law, that bone's going to lay down when there's greater load at a particular region of the bone. You may see these osteophytes that form presence of nociceptive nerve endings that are causing facet pain.
Now, you just went through a really great discussion of the transfer of loads and how that's going to affect change the fundamental ability of the facet joint to move and to, perform its function. Now that loads have shifted, facet fusion, as a way of treating some of these things, what are the best or perhaps preferred indications to go that route, to go with a facet fusion fixation approach? And if you go that approach, what sort of contraindications should a surgeon be aware of?
Well, the first thing I'm going to say is when we talk about indications, and if you're thinking fusion, think about it as a lot of the studies, and we'll get into this, will show that if you're testing these in an in vitro biomechanical test, you're basically getting similar performance. But again, think about the environment you're putting it into. If you've got one segment and you're going to fuse the facets and you've got ample anterior column support with a cage, for instance, then most likely you're going to be just as successful as pedicle screws. You can think about the patients, if they might have somewhat compromised bone, maybe the facet screws would work better. You're not going in with large, heavier, beefier screws, and it's a gentler environment. But again, remember form and function. The facet is cup shaped. It has a gap pressure. It needs to be in compression, basically. And so if you distract that facet joint, or if you put the screws in across it, if you're using transfacet screws, and then you distract it, most likely they're going to break and fail, because again, the form is not designed to be in distraction or tension. It's designed to remain in that cup shape where there's contact and an interface of cartilage between the two. And there's actually an ideal gap pressure that's there that maintains that structure and helps its function in resisting the motions we discussed. So when you think about using facet screws with fusion, think about the patient criteria. What is the level of instability, for example? If you're talking about multiple segments, then maybe facet screws may not work with small interbody devices, when we talk about it being similar in biomechanics, it is in specific situations. It's actually used as an adjunct, just like pedicle screws are, to fusions. And you want good anterior column support to help resist and offload the facet screw. Don't make the facet screw, or don't make any implant work harder than it's designed to do, because something's going to fail. If not the bone, it may be the implant. But what I've got here is the FDA indications. Now there's a lot of newer technologies out there that exist that are coming back with respect to facet screws. And when you look at the indications, and this is a newer indication, and after I'll show you kind of an FDA guidance indication as well, but they're intended to stabilize the spine as an aid to fusion by transfacet fixation. The newer technologies are slightly different. Not all of them are transfacet. There's some novel, interesting devices that we can talk about too, that basically go what I call inline into the facet, cage-like. But they're doing, the indication is similar somewhat to that of pedicle screws. However, you can see there are a lot of other indications from an etiology perspective. Again, it's more about thinking about the criteria and the stability or lack thereof at the specific levels, and how many levels are we talking. If you're talking multiple levels, then you may want to think about pedicle screw fixation for that.
Thank you, Lisa. And I wonder if we could just take a second and help us by comparing the facet fixation approaches and a pedicle screw approaches. Compare and contrast. Does one indication lead more to the facet pedicle, or excuse me, facet screw? Do other indications lead more towards pedicle screws?
I would say yes. I just like putting everything into two separate buckets, because there's so many factors that can play into this. It's more about understanding the biomechanical environment, for lack of a better way of saying it. But honestly, we talk about multiple levels. If you did segmental fixation at multiple levels, but there wasn't a lot of motion or instability or curvature, if you didn't have to correct any type of curvature, keeping the facets in their respective neutral, I call it compressed, but neutral cup formation, somewhat compressed, so that you've got the pressure to contain it, and being able to do that and not having the facet screw, if that's the form of fixation, work harder at trying to resist that, because it'll fail. Those are the kind of situations you have to think about. You're probably not going to use it in a patient that has, two planes of curvature based on the degenerative process, for instance, or they need a lot more correction. And biomechanically, they've been shown to behave similarly when you're looking at a single joint and comparing apples to apples, obviously.
Where does bone quality come into this discussion of pedicle screw fixation versus facet joint fixation?
It definitely plays a factor. Now, obviously, the indications do not talk about, you can't, they're not contraindicated, obviously. Well, they are contraindicated for osteoporosis and osteomalacia, but bone quality, let's face it, as we get older, our bone quality isn't like it used to be. It doesn't mean we're osteoporotic, maybe osteopenic, maybe borderline. We might still have somewhat healthy bone, but it does change. So it may be a better alternative, especially if it's one segment with interbody fusion, using a facet screw in someone that has somewhat compromised. Now, if they're overweight, obese, smokers, etc., then it's probably not a good solution, because they're already at a higher risk, those patients, of pseudoarthrosis, etc. And
Now,
that
right. And multiple levels, degree of degeneration, Those I'm sure are factors as well, aren't
They
they?
will definitely play into this
Okay.
as well
And
because it changes the biomechanical environment.
we keep talking about screws and the facet and other forms, but it's really interesting to me to see how innovation kind of flows around, and I think it's coming more and more into the facet area as well. What are some of the new technologies, the competitive landscape, if you will, for facet fixation?
I am so glad you asked that because, and that's why I said I really like the facet joint. For a while, it was the facet screws that kind of fall out of favor. Everybody's developing the latest trend. Yes, I did say that, or the latest fad, but
Mhm.
they come back kind of like bell bottoms from the 70s. I wasn't born then, so I wouldn't know. But but um but it does come back, and now they're coming back with some very interesting novel approaches. We've seen it in sacroiliac joint, obviously. We used to go across, now we go what I call inline, some people call it posterior, and we're starting to see that with the facets as well. You know, we've been through, there's been a few where we're looking at, you know, wedges or discs that may allow for motion or not, et cetera. But now we have two that are actually cleared. There's many facet screws that are your traditional that have been cleared, but now we're starting to see two. These are just two examples. Providence Medical's, and the MRW is the product code that the FDA uses for facet screws, and these have the same code as transfacet screws that were used as well. But they tend to be, well, the PMT, the Providence Medical, is more like a wedge with screws. I'd call that an integrated cage type structure. They're used with anterior interbody cages, I believe. So now you've got your anterior column support and you have your posterior support. And if you look at the indications here, there's three of them because they talk about how they need to be placed, and then you can provide it. Obviously, it serves as supplemental or temporary stabilization as an adjunct to one or two levels of interbody lumbar fusion. So now it's increasing, it's basically saying, okay, at these multiple levels, you're probably as good as pedicle screws. That would be the interpretation, assuming they probably had to show that. And then we have, this is the Surgentex facet screw. And it's a smaller cannulated screw that basically goes in line within the facet joint as well. And it's small enough, which is what I like about it too. It has the fenestrations, etc., but it's small enough so that you aren't distracting that joint. You don't want to distract that joint. You want to make sure you stabilize it, but don't distract. If you stabilize it, obviously that stability adds to an enhanced fusion success.
Absolutely. Absolutely. So the biomechanics of facet fixation, how do they compare with traditional pedicle screw fixation?
They actually, I've got a bunch of comparisons here. Now, I did cite, I'm sorry, I cited my own study here. This was years ago. This was traditional transfacet screws.
It's your show. You could cite, go away. That's great. Just keep going. You bet.
But this was, I did single motions, yeah, a single FSU for, yeah, not
Yeah.
one, but these were tested. They weren't tested on a full lumbar spine, for example. This was way back when, quite some time ago in 2003, where we took motion segments with pedicle screw fixation, no anterior interbody support, and compared them directly with facet screws, same exact setup, and we cycled them long-term repetitive cycling. And statistically, they were equivalent. There's been other studies here as well, which was encouraging because we're seeing with the, even with the cervical facet screws, the same types of results. The one in clinical biomechanics and Stone et al. As well are seeing that basically they're seeing similarities with that equivalence between pedicle screw fixation and facet screw fixation. Now, I don't like to generalize these because again, it depends on the situation. Think about the biomechanical environment. You know, I'll get hate mail. what do you mean? But this isn't true. I put this in, blah, blah, blah. Again, think about the biomechanical environment. Because that's very, very important with respect to, would you expect to see that? Respect respect the form, the
There you
anatomy
go.
of the
There you
facet
go.
joint,
Form and function. You
form
bet.
and function.
Well, it's and I think this is a fascinating subject. I think that this is going to lead us, and I think, into some very interesting, more personalized medicine, more personalized treatment of patients. So, how do you effectively decorticate and prepare the facet joints for fusion? Or do you have to? Is that even necessary?
I would say yes, you do, because you
Mhm.
have cartilage lining the facet joint so that
Right,
it
right.
slides. In order to decorticate, you want to get down to that bleeding bone angiogenesis. That's what you need, especially if you're filling your novel technologies, the newer ones out there with bone graft, like the cage like, or even the screw itself. You need that. So you want to decorticate. Again, respect the anatomy. How much do you want to decorticate? You don't want to take too much off because you'll compromise the cortex layer, you'll weaken it. There is cancellous bone inside that facet joint. It has a thick cortical layer, but still, you want to be able to do it so that you're not getting what we would call subsidence in the facet joint. But it can occur. So nice bleeding bone, just like you would with the end plates.
All right. All right. Good answer. Now, um, uh, you're doing interbody fusion. You want to supplement that interbody fusion. You do single level, multiple levels, whatever. Let's start with single. Maybe it changes with multiple, but you want to supplement that interbody fusion. In your judgment, how much of the facet joint should remain intact?
I think I do have a slide on this too. Here we go. Yes, so that is a fantastic question because everybody wants to know. The literature, uh, some of it may contradict each other. I know when I would run biomechanical tests, I would stay, you do these sequential removal of the facets. And, some of the studies said, oh, well, at 50%, we start to see a reduction. Now remember, cervical spine facets are coronally aligned, and lumbar spine is sagittally aligned. But still, you're in
That's
this,
very important. It's very important.
it's very, very important.
Sorry to interrupt. Continue.
No, but
Yes.
it's true. Form and function, right? We're bipedal. We have a unique curvature because our form must match its function, and so do the facet joints. It's almost a safety mechanism in the cervical spine. But what you're seeing here is 3 or 4 studies where they looked at facetectomies and how much of the mechanics had changed and reduced or increased. So they looked at both unilateral and bilateral removal of the facets. Unilateral, this is the whole facet unilaterally, you had a 32% decrease in strength. That's not good. Bilateral, you got a 53% decrease in strength. And then you had much more axial rotation, much more distraction. And these are negatives with respect to the facet joint, because the facet joint's function is to help stop over rotating and over distracting. When you get to Rayner et al. Had shown that when you took 70% of the facets, you got approximately 30% decrease in the shear strength. And then 50%, you had reduction in the coupled motions where you can do rotation, you'd see rotation and translation. But this does, again, increase the risk to distraction dislocation. There was some contradictory literature that said, look, 25% removal of the facets will increase your translation, but you won't see a change in the coupled motion. I still think when we would remove the facets, 25%, you want to stay below that if you're going to do a removal, approximately. And again, it depends on the state of the facets. How, are you talking hugely hypertrophic, et cetera, but it's best to stay, because not only are you removing 25% or less of that facet, but you've also compromised the capsule. And compromise of the capsule actually results in a reduction of the ability to remain that tensile forces of that capsule, which resist distraction too,
You know,
of the facet.
Lisa, that leads right. So we had another question from one of our registrants. Yeah, I mean, set joints are synovial, they're synovial lined, they have
Mhm.
fluid, they articulate for a reason. It's function, it's load sharing, all of these complicated factors in one tiny little joint, and one of what, 22 of these joints, I think, something. So, I mean, if that's their function, should they be fused when you do an inner body approach?
It, they it's a beautiful mechanism of load sharing. So if you're going to fuse the anterior, and remember, everything's viscoelastic, bone, tissue. Bone is still viscoelastic. So you're always going to have some semblance of motion, albeit very micro motion, but still. Um, Again, if you do a good anterior fusion, we're always using supplemental regardless. Even if it's integrated, the screws are supplemental for that
Yep.
integrated cage, for instance. But you want to have this added supplemental fixation to help offload or share the load, excuse me, with that interbody. So, doing a facet
Mhm.
fusion is not a bad idea because you're sharing that load. And again, think about the biomechanical situation. Does it apply? Does it make sense? What kind of motion are you seeing? Don't distract. That'll cause the
Right.
screws to fail. You need a stable segment. And having anterior and posterior column stability for fusion is, to me, makes a lot of sense biomechanically.
So you want a stable segment, don't over distract. Um, so is there a role for bone graft in this facet joint fusion paradigm?
I think so because the bone graft is that attractive medium. So if you get nice,
Mhm.
I guess, bleeding bone, but you've done a nice decortication, and you've got bone as your interface, then it helps attract the cells
Of course.
with respect to having earlier osseointegration into the open architecture, open pores of the implant.
So facet stabilization, effectiveness of distraction, bone allograft. How would you compare that with mechanical methods of distraction?
I think, dare I say it, I think distraction is a little bit of a dirty word in the
It
facet
is.
world. People
I'm
go, oh
getting
yeah.
I'm getting that impression. Yes, I am.
And again,
Uh,
it's
and it might be worth just explaining further why distraction is something to be wary of.
because when you think about if something's over compressed, you want to distract it to bring it back to neutral. Well, what's
Mhm.
neutral?
Mm.
Its original form. Now, I talk about original form. You don't want to take a 65-year-old spine and put in cages that are going to restore it back to its 20-year-old curvature if there's a loss, for instance. It's kind of the same with the facet joint. You don't want to go in and reconstruct it as if they're a healthy younger facet joint. You want to go in and stabilize it because you're now it's going to take less work and less energy from the implant side to stabilize, lower risk of failing. So when you think of distraction, taking it from its original form and distracting, that's a bad thing because it's not designed to do that. Again, we're born perfect. Some of us stay that way.
I know
I'm kidding.
you do. Yeah. Yes. Yeah.
But you want to respect that anatomy because it has that form for a reason. Don't try to restore it to something that it wasn't,
Mm.
but restore it so that it can regain its function, even if it's
Excellent.
part.
Excellent advice. Now, I'm really intrigued with the karma system from Spinal Elements, and I know there's another one. Is it ION? Have you had a chance to look at those and how do they compare or contrast with, for example, facet screws?
I have actually. And let's see. So looking at the karma, it's not indicated as a facet fixation system. It's actually aligned more with its indications with pedicle. So it's corticopedicular spine fixation, and that's how it's characterized. And again, it is put into a little bit of a different bucket than facet fixation, even with the novel facet fixation systems out there. I like this though. I like when there's different types of implants out there. It's not a me too. Neither is the Providence Medical, neither is the Ion. And it shows that we're progressing in the right,
Yeah.
along the right path. But again, when you look this up, its indications are not the same. It's interesting because again, they too showed that the karma was equivalent to pedicle screws. And it's more of a circumferential fixation system. It's interesting because it's peak. And again, it can come in with the gentler, kinder environment for those that their bone isn't, it may lack a bit of integrity there. Obviously, it may be somewhat compromised. Not osteoporotic osteopenia, those aren't the indications.
Well, and furthermore, post-operatively, you're going to get better visualization if you're using Peak anyway. This we know for sure.
Exactly. And it
Um,
basically goes around the facet joint in
oh,
through the
and
pedicle.
and that's and that again, that's also what I liked about it too. So, um, when is it, in your opinion, when is it clinically acceptable to fuse only the facet joints? Is it only used as an augment to interbody fusion, or are there possibilities where it would stand on its own?
Ugh, it's a little bit of a loaded question. Um, most the indications, obviously, sticking with what they're cleared for. Some indications will say must be used as supplemental fixation, aids fusion. Now, we know that Europe and even in the US, there's some folks that do strictly posterior fusion. And in situations like that, it may help. But again, it's about that biomechanical environment. It's always good to have anterior column support. Sometimes you can't put that in certain patients, and especially older elderly patients that may need more support. But you don't want to go in there, and you really can't with pedicle screws and have interbody fixation. It just may be a little too risky. You might be able to go in and stabilize with facet joints at a level or two because they have stiffer tissues. We all stiffen as we age. But with
Well,
that said, you might be able.
yes, no, that's right. As you said, it's always good to get anterior column support for sure. Um, so are any disc mechanics considered in the facet joint replacement technologies? Interesting question. Any disc mechanics considered in the facet joint replacement technologies?
Yes, they'd have to be. I mean, when you think about,
Yes,
it's
I guess
it
so, right? Yeah.
it's again, it comes back down to, all right, how bad is your disc? Now, I've seen systems where it's like, oh no, 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 no. You can have a disc in this situation where there's basically dust with what's left with that disc space, and it's just stiffened, dry tissue. You've got degenerative facets, for instance, and I'm using that as an example, may not be a perfect candidate. It's going to be the same for facet replacement systems. You don't want your facet replacement system to do all the work either. You don't want it to control the spine. You want it to aid any device. You want it to aid the tissue for its purpose. So you have to consider the disc mechanics there as well as the facet mechanics.
Form and function.
Exactly.
Absolutely. Well, I think we're getting we're running out of questions from our audience. I think we're doing, let me just double check, make sure I haven't forgotten anything. Um, There were a couple questions here on approval requirements or design considerations. Do you have any closing thoughts on either one of those two topics? So that would be approval requirements or design considerations. And I suppose in one sense, perhaps the questioner was wondering, as these new technologies come in and as we consider with, our better understanding over time of the biomechanics, we begin to understand better how the facets play into everything else. So again, do you have any closing thoughts on approval requirements or design considerations for some of these new technologies?
Yes, I always have closing thoughts. You know,
Right.
um, definitely. One is when we talk about approval, it's really, if it's a 510(k) pathway, it's a clearance. Approval is a PMA. So if you want to go for a PMA, you've got 20 million, maybe more. I think it's even more than that in 10 years, go for it. But when you're talking about FDA clearance, getting that 510(k), the best thing is, this is my favorite line, show me the data. You want to prove claims, show me the data. Show your surgeons the data. Well, from a marketing perspective, you want to make sure you've got data to back up all of your claims, and even trying to get novel claims, newer claims, you've got to have the data to show it.
So even de novo, even 510(k) clearance, show me the data.
Show me the data. That's
All
it.
right.
You want to
All
show me
right.
how much
All
better your
right.
performance is?
Just
I want to see the data.
tattoo that on your forehead. Show me the
Yes.
data.
And
Okay.
then
Design.
my favorite saying. So I'm always talking about form and function. Respect the anatomy. We're born perfect, but in a manner where our anatomy dictates our function. Remember that. So it deserves respect. And if I could sing, I would sing Aretha's song, but it's cup shaped, it's compressed, it acts as a mechanical stop because of its form. If you disrupt that form, you disrupt its stability and you disrupt its function. Avoid over distraction. You want it to aid the tissue, like every implant, whether it's a motion preservation implant or a fusion implant. You want to aid the tissue for the function that it's designed for and for the objective you want to achieve.
All
And
right.
I think,
And the implant has to aid facet joint net stability, right?
yes,
And
yep.
okay, wonderful.
And if you don't respect the environment that you're putting it into and you don't understand its form and function, then you could subject it to failure.
RESPECT. Well,
Awesome.
that's our watchword for today's Ask Lisa program. And I want to thank Lisa as always. I learned so much from you, and you are just you you break down these complicated subjects into little pieces that even I can understand. So thank you very much for that. And
Thank
audience,
you.
thank you all for participating and helping to create this program, because we can't do this program without you. Your questions are the content for our program every time. So stay tuned to our next Ask Lisa. And I would be remiss if I didn't remind everybody that we are going to do a live Ask Lisa at this coming North American Spine Society conference in Chicago.
I'm so excited. I heard you're going to have prizes.
Yes, I guess we will. Yes, and food, hors d'oeuvres, drinks. It could turn into a party. You never know.
Oh, you know.
So never know. All right, Lisa, again, thank you so much. Audience, thank you so much. And we will see you again at our next Ask Lisa.
Thanks, Robin. Thanks, everybody. Appreciate your time.